Shock is a very difficult concept. We're going to talk about it over the next 3 lectures, finishing with a particular type of shock, septic shock. In this first lecture, what I want to do is give you a method for approaching hypotension in general and see how it correlates to shock. I will warn you, because I have come up with these concepts and these words and these nomenclatures myself, and I use them a little different than they are in the literature. So if you go read about shock, you're going to hear the same words, but in those papers they're regarding something a little different. So as you begin this, I want you to just explore a method for approaching hypotension and then a framework for what the body looks like in reference to different types of shock. This is going to set you up for the approach to shock before we move into how to pick a vasopressor and then finally septic shock. Let's start off with the first method for building a differential. And it's an equation. It is the mean arterial pressure is equal to the cardiac output times the systemic vascular resistance. Cardiac output is made up of heart rate and stroke volume. Stroke volume is preload times contractility. The first thing to recognize is that the body wants to maintain a mean arterial pressure such that if the cardiac output falls, it will compensate by increasing systemic vascular resistance. If any one of these 3 components of cardiac output fail, the body will attempt to adjust by increasing them all and systemic vascular resistance. If systemic vascular resistance falls, the body will compensate by increasing cardiac output, by increasing any of the 3 elements of cardiac output that it can adjust. The classic way of looking at shock doesn't help you choose what to do next, which is why I don't use it. But let's discuss briefly. I'm going to put it down here in really small print so that you know to mostly ignore it. The classic models of shock include distributive shock, cardiogenic, hypovolemic, and obstructive. And you'll see the dashed line down here. This dashed line correlates to the dashed line that's up in our equation. The idea is that distributive shock and systemic vascular resistance are the same thing, whereas these are components of cardiac output. But as you'll see, we will use this nomenclature in the equation, but what you will learn from my method is what's the next step. This formulation does not do that. So as you read literature about shock, these are the words you'll see, but as you learn to deal with patients who are in shock, you will learn that these don't help. Let's come back up to the equation and see how this correlates. In mean arterial pressure equals the cardiac output times systemic vascular resistance. And there's a dashed line through the X. Why? Because all causes of shock on this side all have to do with systemic vascular resistance, and all shock on this side have to do with cardiac output. And that's the first element to the approach to shock. What I want you to see is that systemic vascular resistance is tone. It is how constricted the blood vessels are. Cardiac output is how much whomp is on top of that tone. See this as diastole, and this is systole. Let's play with this a little bit. The quintessential blood pressure is 120 over 80. If someone has increased systemic vascular resistance, but no change in the cardiac output, so this is someone not in shock, I want you to see diastole as tone. if they increase systemic vascular resistance, the diastolic tone goes up, the diastolic pressure goes up. Let's say it goes up by 20 points. The systolic WOMP is 40. We've increased systemic vascular resistance by 20. The WOMP hasn't changed, 140 over 100. So you see that the diastolic component has gone up. As this person begins to go into cardiogenic shock, that is, they lose the WOMP, the WOMP begins to disappear. And all of a sudden, the pulse pressure is narrow. As they begin to go into shock itself, they lose the blood pressure. They still have a narrow pulse pressure, but now their blood pressure is lower. So I want you to see that a narrow pulse pressure equals shock from cardiac output. No systolic WOMP. This is the diastolic tone represents an increase in systemic vascular resistance. As the WOMP disappears, the blood pressure slowly trickles down. The body tries to maintain as much tone as it can, but as the patient goes deeper and deeper into shock, the blood pressure continues to fall. The systolic WOMP still is nothing, and the blood pressure begins to fall until they die. But also notice that an increased systemic vascular resistance means something to peripheral circulation. And consider what happens to you when you get cold, sitting in a lecture hall. Your fingers get cold. That's from vasoconstriction. Your fingers and your toes auto-regulate, so when it's cold, it shunts blood back to the core. But your shins and your ankles will not have been cold, because those still get full perfusion. When a person goes into shock and they have a narrow pulse pressure, the diastolic tone is trying to sustain the blood pressure. So there's so much vasoconstriction that no blood flow gets to the extremities. Thus, if someone is in a cardiac output shock and the systemic vascular resistance is attempting to accommodate the low blood pressure from a low cardiac output, what you'll get is a narrow pulse pressure and a cutting off of the blood vessels. So you'll also have a cold extremity. So when you walk into the ER and you see a patient you've been consulted on who might need to go to the unit, you see their blood pressure is 70 over 60 and you touch their extremity and it's cold, that's probably cardiac output in nature being compensated by systemic vascular resistance. Let's go the other way. Let's say the person is going into shock from a decreased systemic vascular resistance. Initially, the cardiac output is going to maintain itself, but what you're going to see is a drop in the diastolic tone. The pulse pressure begins to widen. And as the person gets deeper into shock, the cardiac output can't keep up and the blood pressure begins to fall. So what you'll see in shock from a loss of systemic vascular resistance is going to be a wide pulse pressure. And because there is a loss of systemic vascular resistance, you're going to get peripheral vasodilation. That means blood flow is going to go to the extremities when it shouldn't be. It should be being shunted back to the core to maintain the diastolic perfusion of the coronary vessels and systolic perfusion of the brain, but it's not because the systemic vascular resistance is broken. So if you touch their extremity, it's going to be warm. And this is important. It's not their hands and their feet, because those auto-regulate differently. It is their shins and their forearms. If they're warm and there's a wide pulse pressure, it's a problem with systemic vascular resistance. If there's a narrow pulse pressure and they're cold, it is a problem with cardiac output, and systemic vascular resistance is attempting to compensate. So those are two physical diagnosis clues you can use to determination of shock. Let's go over an actual differential based on this equation. First, let's do systemic vascular resistance. These are going to be the things that cause the diastolic tone to be lost. That is, the loss of sympathetic tone that causes vasoconstriction. And whether that's going to be inflammatory mediators that overwhelm the vasoconstrictor response or loss of sympathetics, it doesn't matter. If you don't have any one component, you vasodilate inappropriately. The big one is going to be sepsis. Very similar to sepsis, even though this is inflammatory mediated by interleukin-1, is anaphylaxis. Anaphylaxis is histamine related, but both of these cause dilation. Spinal trauma can do it by transecting the sympathetics, as can anesthesia, particularly the epidural that became intradural, and Addison's disease. It's strange and bizarre, but pheochromocytoma, a kind of a letdown of the pheo flare, can cause a reduced systemic vascular resistance, but I'm not putting it up there. Sepsis, anaphylaxis, spinal trauma, anesthesia, and Addison's are what you should think of for problems of systemic vascular resistance. If we move over to cardiac output, we make our loop around the different elements of cardiac output. For heart rate, it's either too fast or too slow. Period. It doesn't matter what the rhythm is. If they're in shock, you're going to fix it. And if you remember from the AC lesson in a nutshell, they're too fast and in shock, you shock them. They're too slow and in shock, you pace them. It's not about rhythm interpretation. If you see someone is in hypotension as a result of an onset of arrhythmia, fix it. You should always start here because you can fix it in seconds and reverse the shock, and then work your way around the equation. For preload, it can be one of two things. You can simply be preload down, that is, volume down, which is, remember by the mnemonic, the 4 Ds: diarrhea, dehydration, diuresis, and hemorrhage, which captures anemia and blood loss. But there could also be other things that compromise preload. Conditions that don't allow enough volume to get back into the ventricle. The two things that impair venous return to the right side are a tension pneumo or a pericardial tamponade. Tension pneumo and pericardial tamponade impair filling to the right side. There's enough volume, but something is preventing from getting in. Things that prevent filling of the left ventricle are going to be pulmonary hypertension and a pulmonary embolism. These 4, by the way, are obstructive shock. The green is hypovolemic. The heart rate in red was cardiogenic. And we finish with other causes of cardiogenic shock under contractility, which are going to be essentially CHF, MI, and myocardial contusion. You, as a medicine doctor, will not see myocardial contusion. That's in severe trauma. So I want you to just recognize why I do this the way I do it. And I'm going to ask you, if someone has a tension pneumothorax and they are suffering from shock, what do you think the initial step is going to be if they are preload down? The answer should be obvious. You give them volume. Now you know to do a needle decompression, but who has a needle ready? If they're sitting in front of you, give them some volume. Try to expand the venous return to the RV. If they're volume down, what are you going to do? It's a preload issue. You give them some preload. Give them volume. If they have a pulmonary embolism and they're in shock, what's your first step? They're preload down. Give them more volume. Yes, you're going to use TPA to break up the PE, but the idea is, as you go around and think about what is deficient, what type of shock it is, is less important than which of the equation is broken. Because if there's an issue with contractility, you're going to support the contractility. If there's an issue with preload, you're going to give them preload. If it's a problem with heart rate, you fix the heart rate. And if it's a problem with systemic vascular resistance, you fix the systemic vascular resistance. And this classic model of shock that you're not going to see again in this video doesn't account for that. So as long as you know that these four are obstructive and the volume down is hypovolemic, you can then correlate this method into the classic method. So far, we have just a list of differentials. So when you see someone who is hypotensive, when you see someone who has orthostatics, when you see someone who's in frank shock, this is what you should do. Now it's based on the equation, and yes, you have to memorize which is in each one, but I will tell you that in clinical practice, when I approach a rapid response or approach a patient in the ER who is in shock, I actually go around this loop asking questions and obtaining laboratories which will help me evaluate for each one. This is a method for remembering what diseases are involved in shock. Let's talk about how you identify shock in the first place. That is to say, there is obvious overt shock. And this is a person who has a systolic blood pressure less than 90. As you enter the intensive care unit, what matters more are MAPs or someone who has a MAP less than 65. But there's two other types of shock that people miss. One is occult shock, and the other is a shock index. That is, people who are not in frank, obvious shock, but who you should at least be considering taking to the unit, even though the numbers don't say so. Someone with a shock index has a heart rate that is greater than the systolic blood pressure. This can happen in younger, healthier people. That 23-year-old sickle cell who has a UTI. Her heart rate might be 170, but her blood pressure 101/50. She's walking around asking to go to the bathroom. She is still in shock because she has a shock index, but she can compensate. Her cardiac output is good enough to sustain a heart rate of 170 because she's so young. She may not need to go to the unit, but you could justify her admission by the positive shock index. But if you've got an 80-year-old whose heart rate is 110, their blood pressure is 100, systolic, you should start thinking something's wrong, because chances are that person does not have a low blood pressure at baseline, and that shock index is indicative of them going the wrong way. Likewise, in occult shock, what you'll see, this is difficult to do because you need to have a system with lots of continuity. You see someone in clinic and they constantly come in uncontrolled with their blood pressure. And all of a sudden, sitting in the emergency department, they look great. And you might bypass this 120/70 if you didn't have these values from clinic and say, well, their blood pressure is fine. Actually, they're looking fantastic. But really, they're supposed to be on 5 different antihypertensives, and even off those antihypertensives, their blood pressure is normal. That's actually occult shock because their blood pressure is lower than they're used to. In this person, her blood vessels have already adapted to this, and she needs this hypertension in order to sustain perfusion through those diseased vessels. This doesn't cut it. She may actually be in shock. This is how to identify someone who might be in shock. The equation is used for the differential. Let's talk about one more way of thinking about the body before we move into talking about which type of vasopressors you use and then septic shock. I want you to think of the body as a tank. The brain is suspended at the top. There's a motor that pushes the fluid towards the brain against gravity. And the goal is to get the water level over the brain. This is an adequate perfusion, a tank in normal size with enough water and a motor to get it there. There's 3 ways that this system can break that will present with the brain being poorly perfused. And after all, that's the purpose of our body, is to perfuse our brain and make us us. The first is that the tank could be too big. The motor still works, but there's just not enough volume to get to the brain. Systemic vascular resistance has increased. The tank is too big, and now there's not enough fluid to fill the tank. This is an issue with the tank and reflects systemic vascular resistance. You might lose the pump. The tank is normal sized, but now without the pump, there's enough fluid to get to the brain, but not enough force to get it there. This is a broken pump and is essentially contractility. One way the pump can break is with a heart rate that's too slow or too fast. And finally, if you're following along, you could just have a hole in the tank. Brain doesn't get perfused. The pump is trying to push fluid up to the brain, but all that happens is that it leaks out. This is the fluid and is issues with volume or preload. And this is where you have to be careful. This is the terminology I use. It makes sense to me. It probably makes sense to you. But you'll see tank and pump and fluid in terms like it in the literature and some ways of thinking about it which are a little different, which I know is frustrating, but this is the way it works for me, and it's worked for students under me. I suggest you start thinking about it like this because we're going to use these concepts as we talk about vasopressor activity and in septic shock. So to review, the biggest thing you should take away from this lecture is this equation. The mean arterial pressure is cardiac output times systolic vascular resistance. Cardiac output is heart rate times stroke volume. Stroke volume is preload times contractility. And any time you encounter a patient who has hypotension, write this out. Then you should begin committing to memory the different potential diagnoses and recognize that systemic vascular resistance represents the diastolic tone, when cardiac output represents the systolic whomp. So you can use the blood pressure and your physical exam to start you down the major pathway so you know what to do next. We're going to talk more about that in the coming lectures. That is Shock 1, Introduction to Shock. We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.